Sound good?
Working all the time.
Okay, we're ready to go. Well, good evening. It's pretty, and we're going to go ahead and get started on time. And thanks for coming out tonight. We're going to talk about diabetic emergencies tonight, and just talk about generally a little bit about diabetes and what we have to watch in the field. So this is, for those who have been to the talks before, you know that I tell you that diabetes really complicates everything. And that's just a fact. It doesn't matter what illness we're dealing with. If the patient's diabetic, it's more complicated. This is an illness that affects a lot of people. It's about 1 in 10 in this country. So I mean, it affects 26 million people. We got what, 300 million in the country. So and it's expensive. Probably one of the most expensive illnesses for the healthcare system. When we talk about diabetic emergencies, there really are two types: high sugar, low sugar. And I remember back in the days of being an EMT, back in the 70s, we didn't have finger stick glucometers, and it was always tough for me to try to remember which was which, when the patient presented. And it still is. I mean, some patients look at them and say, oh, is their blood sugar high, is it low? What we don't want to miss in the field is getting to the patient with low blood sugar. So when we talk about diabetic emergencies, we have hyperglycemia, high blood sugar, and that is diabetic ketoacidosis, and an entity called hyperosmolar hyperglycemia. We'll talk about those in a little bit. And then the other entity that to me is more worrisome is hypoglycemia, the patient with low blood sugar. So again, diabetes affects a lot of the world's population. And when you get over 60, it affects about 1 in 4 people. Most of these are type 2 diabetes, 90 to 95%. So adult onset, not insulin dependent, the vast majority. But what's interesting is the incidence of diabetes has gone up 700% in the last 50 years. So think about that. For those who've been around a little bit, since let's call it 1960, we've seen a 700% increase in diabetes. Why do you figure that is?
Their food's processed, eating habits, work habits.
Yeah, and you think about, the last, in 1960, McDonald's was just coming on the scene. I mean, really, we didn't have fast foods like we have now. We didn't have Kentucky Fried Chicken. We didn't have McDonald's. We didn't have all these fast drive-ins. People ate at home. They carried their own lunches. We were a manual society. Today we're a service society. Look at all the people that sit and earn their living by working on a cell phone or doing something service rather than manual labor. Another thing was the obesity crisis. And really in the last, 30, 40 years of less activity and people overweight, and that's what has happened. But it's led to the fact that diabetes is a major cause of death, like the 7th leading cause in this country. So I said that diabetes causes every illness to be worse. And diabetics are more likely to die earlier than non-diabetics. In fact, a man diagnosed with adult onset diabetes in his 40s loses 5 to 6 years of life. So, men's life expectancy now, 82, 83 years. You get diagnosed with diabetes, so now your life expectancy is 75, 78 years. Women lose 7 or 8 years of their life expectancy. Stroke risk goes up. Heart attack risk goes up. It's a primary cause of blindness. That's one of the reasons that people who do have blood sugar problems, we insist, hey, look, you got to see an ophthalmologist or an optometrist every year. You got to have your eyes looked at. You got to watch the retinas. You got to make sure you're not getting degenerative eye disease. All these people that are on dialysis 3 days a week, most of them started with diabetes. The combination of diabetes and high blood pressure knock the kidneys off, end up in renal failure. It's a major cause of neuropathy. Well, what's neuropathy? People that just don't have any feeling in their feet. We'll talk in a little bit, but But our body is used to operating in a very narrow range of sugar. So all of a sudden your neurons, your peripheral nerves are getting bombarded with high sugar doses all the time. And you get microvascular disease. So the tiny little arterioles aren't working right, the peripheral nerves aren't working right. You get numbness, particularly in your feet. Diabetics that can't feel their feet, then they step on stuff, they don't know they did it, they get infections, all kinds of problems there. So diabetes is the major cause of neuropathy, that is numbness in the extremities. You know, just like the triangle of fire, you need heat, fuel, oxygen. The body needs sugar, water, and oxygen. The body is an incredible, clean machine. When it's running, you put in the sugar, you put in the water, you put in the oxygen, it burns it for fuel, produces carbon dioxide, that's it. Very, very efficient. But glucose is absolutely key for central nervous system function. Neurons depend on sugar and water and oxygen. And we've talked about before, you know, cutting off the blood flow, cutting off the oxygen, obviously causes CNS dysfunction, but dropping the blood sugar or making the blood sugar too high can cause central nervous system dysfunction. And that's the primary cause that people who get low blood sugars, their blood sugars down 30, 40, 50, are confused because their brain's not working right. And that's why, in my opinion, if we said, what do we have to recognize? It's low blood sugar, because persistent low blood sugar starts causing neuron damage and death and permanent damage. And so we want to fix that. If you give somebody, if you can't determine if they got low blood sugar or high blood sugar and you give them sugar, you're not going to hurt the person with high blood sugar. You're going to save the brain and the life of the one with low blood sugar. And so, take home point. Our usual blood level is about 70 to 150, and that's measured in milligrams per deciliter. Well, what's a deciliter? Deciliter is 100 cc's. A liter is 1,000 cc's, so a deciliter is 100 cc's, a tenth of that. So for every, now 100 cc's, there's 30 cc's an ounce, so that's about 3 ounces plus. So for every 3 ounces of blood, we've got about 100 to 150 milligrams of glucose. And our body requires, if you look through the course of a day, most of us need about 100 grams of carbohydrates for our body to function. And that's just to do daily functions. If you take in more than 100 grams, you're probably storing it away. If you're not taking in 100 grams, your body has ways to make sugar and make up the deficit. So there's 3 sources of glucose. And these are kind of backwards on the slide. We'll start at the bottom. Our first source of glucose is eating. You know, whatever we take in our foods. And so the glucose that we take in our diet is absorbed and basically starts getting absorbed almost as soon as you put it in your mouth. The primary absorption's in the gut, in the intestines. But if you got someone with real low blood sugar and you get that liquid glucose under their tongue, they absorb it just like absorbing nitroglycerin and so forth. So our first source of sugar is direct absorption of glucose. Body uses it for fuel, and it's absorbed very, very quickly once you ingest it. 2 other ways. If you don't have enough glucose, then the body starts breaking down stored glucose. Glucose is stored as something called glycogen. So glyconeogenesis means we're converting glycogen to sugar. And this is what's interesting here. Glycogen requires a lot of water for storage. In other words, your body's storing sugar, it stores it as glycogen, it's got to dilute it and put it somewhere. It puts it in the muscles, puts it in the liver, and so this is the primary fuel, for instance, a marathon runner. They're eating cookies, they're eating snacks, they're using up glucose. Then their body starts using the glycogen that's stored in the muscles. And then when that's gone, the muscles start aching. Those of you who've worked out like that before. And then it starts using the glycogen stores from the liver. And once you use all those glycogen stores is when, if you've been as an athlete, when you hit the wall, all of a sudden it's like, man, what happened? I got no more energy. Yeah, you just used up all your fuel stores. What's interesting about glycogen is if you've ever gone on a diet and you say, oh, the first few pounds is easy, it's the water weight, that's exactly right. Because all of a sudden you're not taking in glucose by mouth, so your body's starting to use up the glycogen. As it uses glycogen, it doesn't need the water to store it, so you pee the water out. And it takes about 3 or 4 grams of water for every gram of glycogen. So if you go on a diet, those first 2 or 3 or 4 days, you're just peeing. Yeah, what you're doing is you're using up glycogen, your body's getting rid of the excess water. That's why you lose that water weight real quickly. So first way we get sugar is direct eating, drinking, direct absorption. Second way is breakdown of glycogen. And the third way is the breakdown of fat and protein, which is the way we really don't want our body to do. It's gluconeogenesis. And what's happening then, this is not near as efficient as the first two. And your body's almost using as much energy to make glucose as it's getting out of it. So you're breaking down muscle, you're breaking down protein, you're breaking down fat. When you break down fat, you get ketones, and it's problematic. But this is the breakdown of fat and proteins is the third way. So you absorb it from your gut, break down glycogen, then you start breaking down fat and muscle. There's 2 hormones that control our blood sugar. It's insulin and glucagon. We eat. As soon as we eat, blood sugar goes up. So we eat a meal that's high in carbohydrates, high in sugar. So food goes into the gut, sugar's absorbed right away from the intestines into the bloodstream, goes to the pancreas. So within a minute, it's in the pancreas. And there's 2 kinds of cells in there, alpha and beta cells. But the beta cells are the ones that release insulin. So the pancreas, the beta cells sense that, hey, I got glucose, I'm going to release insulin so that that glucose can be taken into the cell and used. And that's what insulin does, is it helps the glucose or moves the glucose into the cell where it can be used for fuel. It also, insulin lets your body store the excess glucose. So it promotes buildup of fat. And it also shuts down the release of glucagon. Doesn't need any more glucose. I got plenty of glucose, I'm good to go. So insulin moves the sugar into the cell, helps you build up fat, and keeps glucagon from being released so the blood sugar doesn't go out of control. So insulin lowers your blood sugar. Now, what's glucagon do? Well, glucagon does the opposite. It causes your blood sugar to go up. When you don't have any sugar in the bloodstream, there's no insulin being released, so glucagon's released. Glucagon causes the release of glycogen stores, particularly from the liver and the muscle. So insulin lowers blood sugar, glucagon raises blood sugar. So 2 types of diabetes, type 1, type 2. Type 1 is the juvenile onset diabetes. These guys are insulin dependent. They've got to have insulin. And what's happened, in this is a small percentage of the cases, only about 5%. Child might have got a viral illness, and that's what's believed to cause a lot of this, is any number of viral illnesses which attack the beta cells in the pancreas and wipe them out. So all of a sudden, pancreas doesn't make insulin. And that person is now dependent on insulin from an outside source for the rest of their life. So pancreas islet cells are damaged, no insulin's produced, blood sugar can't move into the cells. So if this is an acute problem, then the body, you've got plenty of glucose circulating in the blood, but you can't produce insulin. So effectively, the body can't use that glucose. Glucagon is released because there's no insulin around, so your blood sugar goes up even more. So it really is problematic. And a lot of times, particularly kids, they'll show up just after what seems like an inconsequential illness, and they're in DKA. Their blood sugars are 300 or 400, and they're acidotic, and they're sick, and they're dehydrated. And what's happened is their pancreas, the beta cells got knocked out, they can't produce insulin, and this whole cascade starts. So type 1 diabetes, juvenile onset diabetes, is an absolute insulin deficiency. And without insulin, these people start breaking down fat and get what we call ketotic. When you break down fat, ketones are the byproduct. That's where the fruity odor on the breath comes from. And within a day, 12 to 24 hours, they're in what's called diabetic ketoacidosis. These folks usually they're really thirsty, they're peeing a lot. A lot of them are very thin, they're weak. What happens over time if it's not controlled, you start getting damage to the micro vessels. So the eyes, the nerves, the heart, the brain, the vessels all get damaged by blood sugars not well controlled. And one of the things about type 1 diabetes, this is usually young people. And one of the most difficult groups to manage are the teenagers who have diabetes. And all of a sudden they have to inject themselves twice a day. That's why the insulin pumps have been huge revolution in management of diabetes. Because the old days, we all know how teenagers can be. So you send off a teenager to school or wherever, and they're supposed to draw up and give insulin. It's like, yeah, they don't need that. Now with the insulin pumps, the sugars are monitored, the pumps take care of it. And so lots of ways you can give insulin. You can give it sub-Q on a regular basis. You can get a basal level you do all the time, and then little boluses as you need it, kind of sliding scale. So the sugar goes up, you give an extra dose. And now insulin pumps are very, very common. So the names of things that you'll see when you guys show up at the house that would tip you off the patient's an insulin-dependent diabetic. If they've got drugs called Humulin or Lantus, those are common forms of insulin. So Humulin R or Novolin R is regular insulin. It's very short-acting. You give it, it acts quickly, it's gone in a couple hours. So it really, you give it, the peaks in about an hour, its effects are gone in 2 hours. The Humulin N or Novolin N is longer acting. It's around for 12 hours. So you give it, it peaks at 1 to 2 hours, it lasts 6 to 12. And then Lantus is longer acting. Onset is slower, and it lasts 12 to 24 hours. So that's only about 3 to 5% of the population that is type 1 diabetics. Type 2 is more common. And this is adult onset, and these are the most common causes. A lot of familial tendencies. A lot of folks are overweight. It's a relative deficiency of insulin, but what's happened is the body has the insulin's not being produced as much as needed, but you still have insulin, so you don't become ketotic, you don't break down fat like a type 1, but your body's become resistant to the insulin. The cells just aren't as resistant in the muscle and so forth as they used to be. So there's enough insulin to keep muscle breakdown and fat breakdown, but there's not enough insulin to move the glucose into the cells and have an efficient machine. Most of the folks that are type 2 diabetics are overweight, and the fact is that many of these folks, if the weight's controlled, if there's exercise, can get that back under control. So type 2 diabetes, obesity, family history is real important. It tends to run in family. Gestational diabetes, a lot of young women go through pregnancy and they get diabetes during pregnancy, and once they deliver, it's gone. There's an association with high blood pressure. A lot of these folks are sedentary. It's more common in African Americans than white. So there are trends there. And some of the things that you'll see medicines that type 2 diabetics use, the most common one now is metformin. And it inhibits glucose being released by the liver, and it helps glucose uptake at the tissue level. And so you'll see medicines called glipizide or glyburide, and what those do is cause increased secretion of insulin by the body. So these are just some names of things. If you pick up pill bottles, you see them, think, oh, this guy's type 2 diabetic. How do we diagnose diabetes? The old days, it was purely on a blood sugar. And it had all these protocols. Hey, if you haven't eaten after midnight, you've been without food for 8 hours, and we check a random glucose a fasting glucose and it's over 125, 126, you're diabetic. Or we can give you a measured dose of glucose by mouth, and if your blood sugar at 2 hours is over 200, you're diabetic. If you're just getting checked randomly, it's over 200, you're probably diabetic, particularly got symptoms. Well, listen, the easiest test now is hemoglobin A1C. A finger stick glucose or drawing blood and sending it to the lab is looking at your glucose at that point in time and that point in time only. A hemoglobin A1C is looking at the average over the last 12 weeks. And we've almost stopped on some of these firefighter screenings we're doing and things. We've almost stopped doing random glucose. We're just doing A1Cs on everybody. Because that tells us, say, look, if your A1C is less than 5.7, you're not diabetic. If it's 5.7 to 6.4, you're pre-diabetic. It's like you need to watch what you're doing. And if it's over 6.5, you're diabetic. That's it. And there's no need to check an A1C any more often than every 12 weeks. In other words, if you're diabetic, you get started on medicine, check your A1C again in 12 weeks. We'll make sure we're headed in the right direction. The goal is to get an A1C less than 7 for good maintenance. And that correlates to the blood sugar level. Yes, sir.
Can diabetes be reversed such that a person no longer has it, or is it?
Yeah, and it's a type 2 diabetic. If in some cases, yes. So if a type 2 diabetic is overweight and they lose weight and they exercise, that's one of the claims to fame of the bariatric surgeries. You know, someone goes in and has a gastric sleeve or gastric bypass, and many of those folks, all of a sudden, their diabetes goes away. So it is, type 2 to some degree is, type 1's not. If you don't have insulin, you're on insulin forever. But type 2 diabetes, folks can lose weight, can exercise and do some things and potentially, get off the medicine. Exercise and weight loss really positively affect your blood sugar, your blood pressure, your blood cholesterol, and your weight. And the weight affects all those other things. And it's pretty amazing. Used to see this in aviators, and these guys would come in when I was, a flight surgeon. The last thing they want to do is end up on a bunch of medicines, because now their flight status is restricted. You get them all in exercise programs, they come back in 6 months, and you can measure the difference. And you see that likewise, patients we see in the clinic. Patients that come in and they've lost 20, 30, 40 pounds, all of a sudden they're not on their blood pressure medicine anymore. Fixed. Same way with diabetes. So yes, in many folks it can with diet restriction, with weight loss, with exercise and so forth. So the goal in treating diabetes is really the goals are the same. Get the blood sugar to controlled 70 to 130. That's the range we want to be in. Get an A1C to less than 7. Treat and monitor blood pressure and blood cholesterol. Most folks who are diabetes end up on a low dose of lisinopril to protect their kidneys. We want to keep the blood pressure down, certainly less than 130 over 80. We want to keep that cholesterol as low as you can get it, less than 150. Watch the calorie restrictions. Exercise is an absolute must for these folks. So you go to a house and there's a question if they're diabetic or not. What do you want to know? While you're there waiting for an ambulance to arrive. One question is, hey, is there a history of diabetes? Yeah, he's a diabetic. He's not been taking his insulin. Well, that gives you a lot of information right there. Blood sugar is probably going to be elevated. Or, yeah, he's diabetic. They've been having trouble getting his sugar under control, and he takes his pills and he gets confused. Well, blood sugar's probably low. So all of a sudden you've got the information. Nausea, vomiting, abdominal pain are real common presenting symptoms in people with blood sugars out of control. Someone shows up in the emergency department, they're throwing up, they look dehydrated, they got abdominal pain. First thing we check in many cases is a finger stick. And in many cases you find out the blood sugar high. And that's the way they present, is with nausea, vomiting, abdominal pain. Polyuria, polydipsia. That means polyuria, peeing too much, polydipsia, want too much water. So the patient says, I am drinking so much fluid, I'm drinking 2 bottles of Mountain Dew, I'm drinking water, and I'm just peeing. I can't stop peeing. Well, that's classic diabetes. Very thirsty, dumping sugar. And wherever sugar goes, water has to go with it. So your body's trying to get rid of the excess sugar, and it's taking water with it. So thirsty, excessive urination, flares, blood sugars out of control, either low or high, can be set off by stressors. Heart attack, infections. So you ask, hey, is the patient, been sick lately? Chest pain, trouble breathing? And they say, oh yeah, we think he's got pneumonia. Yeah, well, that might tip it over. Mental status, diet, and medications, all questions you want to ask at the house. And then, how quickly did this happen? And what's interesting is that low blood sugars typically happen pretty quickly. Someone's doing fine, they're taking their medicine, they forget to have a meal. Happens. All of a sudden their blood sugar, they've been running along at 90, 100, and all of a sudden their blood sugar's 50, they're confused, they're sweating, they look like crap. It's low blood sugar. So low blood sugars occur quickly. On the other hand, someone misses their insulin, runs out of insulin, DKA occurs over a day, 12 to 24 hours. And those patients, all of a sudden, they've not taken their insulin. All of a sudden, they start getting thirsty, they're drinking, they're peeing a lot, they start getting weak, they start getting nauseated, and they get in trouble. The one that's interesting is this hyperosmolar hyperglycemia, and this can occur over weeks, where, this is the old farmer in bibs, and big old guy comes in and a little confused, just doesn't feel good, and you do a finger stick and it's high. You get a blood sugar back and it's 1,000. And you look, this guy's dry as can be, and he's just weak and doesn't feel good, and that blood sugar's been going up and up and up over a period of time. Everything in the human body, the slower it goes, the more the body adapts to it. The faster it goes, the less we do. So this sugar's been rising over days to weeks. So low blood sugars usually happen quickly, DKA over a day, hyperosmolar hyperglycemia, it can be days to weeks. And you always want to know someone using alcohol or drugs. One of the things that absolutely has revolutionized recognizing this is finger stick glucoses. And most diabetics, most family members know how to do that. They've got the little glucometer there. It's like someone falls out in church, there's at least 3 diabetics with glucometers around, so check their finger stick, The old days, I can still remember trying to figure out, okay, is this high blood sugar, is it low blood sugar, and trying to sort it out. And now you stick the finger, and 60 seconds later you get the answer. And it's that's something that we probably don't do enough of, is getting finger stick glucoses on everybody with changes in mental status or any concerns. Obviously we do the ABCs. One of the things they talk about is fruity odor. You smell someone's breath and it smells like they're chewing juicy fruit gum. That's ketones. Ketones that they're blowing off from breaking down fat. Is the skin warm and dry, or are they sweating up a storm? The skin warm and dry is that patient who's in DKA, they're dehydrated. You look at their mouth, and their mucous membranes are dry. On the other hand, one whose blood sugar is low typically is pale and sweaty and heart rate's fast, and you look and their mucous membranes are moist. Now their blood sugar's 30, but their body's stressed and they're sweating. Are the mucous membranes dry or moist? They have a rapid heart rate? Those are things you're looking at. So diabetic emergencies that we want to address are high sugar and low sugar. High sugar being DKA and hyperosmolar hyperglycemia, and low blood sugar being hypoglycemia. So with DKA, a lot of times this is their first presentation. Someone might be 10, 12, 15 years old and have never been diabetic. All of a sudden they show up, dry and peeing a lot, and low blood pressure and fast heart rate. You get a blood sugar and their blood sugar is 350, and check electrolytes, and they're acidotic, and it's a bad illness. I mean, it's, 10–15% mortality. And these folks need insulin, and they need fluids, and they need, most of them, ICU admissions. So what causes it? Well, it could be the first presentation, but the vast majority of cases, it's medication noncompliance. Not taking their insulin, ran out of insulin, decided didn't need it anymore, whatever. Sometimes it's alcohol related, sepsis, overwhelming infections. When older patients come in and they have DKA, you go looking for causes, you're always looking at EKGs, looking to see if they had a silent MI. Diabetics are the ones who don't present the way the rest of us do, and 20% of them have what are called silent MIs, no pain. They could have a blood clot, they could have pancreatitis, they could have an operative problem in their abdomen. Lots of causes can get them into trouble. But the common theme is something has interrupted their insulin regimen, whether that the body produces or whether they can't get it to themselves. And glucose can't enter the cells, so like we talked about a little bit ago, got all this glucose in the blood, but there's no insulin. Because there's no insulin, now glucagon's released. Glucagon causes release of stores of sugar, sugar goes higher. Now, your body, the kidneys are trying to filter this glucose out. It's trying to get rid of it. Well, it takes water to dilute the sugar, so you're peeing. You get a urinalysis and put a dipstick on it, it's got glucose in it. What's also happening is your body's dumping all this water, you're getting dehydrated. And you're starting to deplete sodium, potassium, magnesium, so it really becomes a complex issue to manage. These folks end up in ICUs on insulin drips, and they end up getting magnesium and phosphates and potassium, and they can really be problematic to take care of. There are many times they're down 3 to 6 liters on fluid. They all have to have insulin to recover. You can give them fluids all day, but until they get insulin, and you give them insulin until they stop breaking down their fat, and then you keep running it until the sugar comes under control, and get them back out on a regimen that hopefully they can stick with. The hyperosmolar hyperglycemia, these are the guys that may have blood sugars of 1,000. I think the highest one I've ever seen was 1,300 in that range. And the guy was still conscious, although he wasn't mentating well. But a lot of these are type 2 diabetics that just haven't been well controlled with pills. And a lot of type 2 diabetics don't get well controlled with pills and get supplemental insulin. But they're not well controlled, and typically they get a stressor. They get an infection, they get a stroke, they get a heart attack, something. Sometimes they just don't have enough, they don't have poor access to water. And so over a period of days to weeks, blood sugar goes up. They get this gradual change in mental status. And like I said, blood sugars can easily be over 1,000. It carries up to a 20% mortality as well. So these folks can be 8, 10, 12 liters of fluid down. And so you can't give it to them all at once, put them in congestive heart failure or cerebral edema. So you bring them in, you get them fluids. They didn't get there quick, they're not going to get out of it quick. That's the key. So these guys, thirsty, fatigued, peeing a lot, confused, look like someone with DKA is really what their electrolytes and their numbers show. So high blood sugars, we want to confirm the level. If you do an AccuCheck, you do a finger stick, or the patient has it and the family member does it, it may just register HHH or whatever means high, can't calculate. But IV fluids are the mainstay of treatment. We start giving them fluids. We got to have insulin to make them better. Now, hypoglycemia. So we've been talking about high blood sugars. Patients are, and so the high blood sugars. If you say what's the common theme, yeah, they're confused, but if you have them stick their tongue out, it looks like a desert, and they're really dry, and they're not sweating. The low blood sugars, many times they're well hydrated and confused. But most of the time, low blood sugars are medication induced. They have taken their metformin, they've taken their glipizide, and maybe they missed a meal. So they don't have a diet set like they should. When I was in my 4 years in the fire service, it was an engine company and a medic unit, and it seemed like my partner and I, and it was a period of about 6 months, for whatever reason, we seemed to get this guy about every 6 weeks at 3 o'clock in the morning, within an hour. And when the call went out and had the drink, knew what it was. You show up, and this guy had gone to bed and either had a seizure or was confused, and his wife would call 911, in we go, his blood sugar's 30, and, get a line in him, give him some D50, he'd sign an AMA form, and we'd go back to bed. But the point was, it was a regular cycle we were going through, and this guy was not managing his diabetes well, he was taking his medicines, not eating an evening meal, whatever, and then 8 hours later during the night, he's getting in trouble. And that's what happens many times, is that they're taking medicines, they're not following a diet. So if you're taking this much medicine, you got to take this many calories in, or you get in trouble. So medication changes, alcohol use, a lot of these folks are over 60 and getting into trouble. But what happens is the blood sugar starts dropping. So you've got some insulin, but you don't have enough sugar to support it. So blood sugar starts going down, and the body senses that and releases stress hormones, epinephrine and norepinephrine. And when it releases epinephrine, what typically happens if we give somebody epinephrine? Their heart rate goes up. It's exactly what happens here. Your body's producing epi, your heart rate goes up. So you get tachycardia. But once your sugar gets below 50 or 60 is when you start getting symptoms. Confusion, combative. I mean, these guys are up and they may be wanting to fight you. They're flailing along, and all you got to do, if you get a piece of candy or some instant glucose under the tongue, all of a sudden, in a few minutes, they're good to go. But low blood sugar causes the change in mental status. So at less than 70, confused, sweaty, versus the guys with high blood sugars who are usually dry. Kind of gray, pale, moist mucous membranes, many times sweating. Remember, the sympathetic nervous system, our fight or flight, sympathetic nervous system is what makes us sweat. Same thing here. The body's stressed, epinephrine's being produced, we're sweating, but we're well hydrated. And we're stressed because our blood sugar's low. So what's the common causes we just talked about? Medications, not eating, stroke, shock, sepsis, drug toxicity. A lot of times we don't know the cause. I'm not worried about the cause. What I'm worried about is once I know that blood sugar's low, my job is to get it back up before this guy does any permanent damage to his coconut. So, change mental status, abdominal pain, nausea, vomiting, seizure, short of breath, chest pain, finger stick gives you the information you need. And if you can get one quickly, the blood sugar is 30, you know what you need to do. So, usually fairly rapid onset, can occur during the sleep. Most of them are type 2 diabetics versus type 1s. What would cause this in a type 1 would be an overdose of insulin. And somebody who took too much insulin and didn't eat can present the same way. So what do? Check the finger stick. If they're awake, they're maintaining their airway, they're confused but talking to you, getting oral sugar in them is the way to go. Because if you can get some soda in them, not diet soda, the real thing, or you can get some the oral glucose, the liquid glucose most of us carry, you can get that in them. Sublingual sugar, a sugar packet, put it under their tongue, just like nitroglycerin, it's absorbed right under the tongue. all of a sudden, they begin to wake up to where you can get them something to drink and then get them a cracker or a peanut butter sandwich or something with some protein that lasts a little longer, and they're good to go. But if they're not, then the decision has to be made of giving them IV sugar. So getting an IV in, or getting an IO in, and giving them D50, or giving them IM glucagon. And you know, someone who has low blood sugar, typically we get an IV in and give them D50 very quickly. The mentation becomes normal. Hey, what am I doing? What are you doing here? Well, who are you guys? Where'd you come from? Glucagon takes a little longer, but it's very, very effective. What you're doing is you're giving the IM form of our hormone, which is causing the release or the switching of glycogen back to glucose. So if they're awake and alert, patent airway, oral sugar, candy, blood sugar is going to increase over 15 or 20 minutes. After they improve, get them a snack, get them a meal. Most of these folks then don't need to go to the hospital unless there's another reason. IV D50, we give an amp, which is 25 grams. If we can't get an IV or an IO, we can use glucagon IM, give a milligram. What about glucagon if someone, like that marathon runner, they don't have any stores of glycogen, so they've used them all up? Glucagon ain't gonna work, because that's what it does. It converts glycogen back to glucose. So if you've got someone who does not have any glycogen stores, then it's not gonna work like giving them IV D50. And then again, follow with a snack or a meal, make sure they're okay. There are EKG findings on what happens in many of these cases. Patients get high potassium, so they get EKG abnormalities, and they're fairly classic: peak T waves, prolonged PR segment or intervals, QRS widens out. And if that's happened, if they've got a long PR and the QRS is wide, peak T waves, we're headed for trouble fast. So the summary, the key points. You gotta suspect blood sugar problems in any patient with altered mental status. What I want you to think about is if you're debating whether they need sugar or not, give them the sugar, because you're not gonna hurt. If someone's blood sugar is 1,000, you put a little sugar under their tongue, you take it to 1,100, you haven't done them any harm. On the other hand, if someone's blood sugar is 20 and you don't give them sugar, and now it's 30 minutes getting to the hospital, they're cooking neurons during that time. So you're better off, if you're in doubt, give them the sugar. Low blood sugar, they're cool and clammy and moist and sweaty in most cases, and the high blood sugars, they're dry and warm and tachycardic. I mean, the mucous membranes are terribly dry. But if you got any questions and their airway's intact and you can get oral sugar in them, that is going to, that's your default. You want to treat the low blood sugars quickly, because that's where the permanent damage will come. These guys are in trouble, both of them. But when you're 20 minutes out in the country and you're trying to make that decision, I would say default to giving them sugar, and we can figure the rest out later. And that's it. 45 minutes, right on the money.
Pure sugar.
Not Splenda, not
No,
NutraSweet.
just talking about